This should be a quick talk since I only have to talk about 2 drugs here. And these are my disclosures. So first of all, ARN-509, it now has a name. It's called apalutamide. It's one of the few times that a name occurred before the FDA approval, so maybe they're very hopeful. Who knows? So this is some preclinical data that was published now 3 years ago. And this is a LinCap AR xenograft mouse model. And what this shows is it compares MDV-3100, which is now, of course, enzalutamide, versus ARN-509. And you can see that in these mice, the tumor volume reductions are greater in the mice receiving comparative doses of ARN-509 versus MDV-3100. So this was some first evidence suggesting that the binding affinity to the AR with ARN-509 might be greater than with enzalutamide. And this is an interesting experiment here which looks at the seizure risk. And as we all know, in patients receiving enzalutamide, seizure occurs in about 1% of patients. Let's see if this pointer works. So this green range here, it's from the mouse experiment, shows the sort of minimum therapeutic range of ARN-509. And this shows the therapeutic range of enzalutamide. And this red dotted line here shows the seizure threshold in humans. And what this really shows quite nicely is that the efficacious range of ARN-509 is way below the seizure threshold, whereas the efficacious range of enzalutamide actually is above the seizure threshold. So this is one of the theoretical reasons why ARN-509 might have less of a seizure risk. The second reason is it penetrates the blood-brain barrier less. It still gets in. Initially, we thought it didn't. It does penetrate the blood-brain barrier, but less so than enzalutamide. So this was the phase 1 trial published by Dana Rathkoff. This was 29 patients receiving multiple dose levels of ARN-509. And as you can see here, once you get above the 3rd or 4th dose level, there was a fairly good chance of a PSA response. Overall in this trial, there was about a 48% PSA 50 response. So of course, showing some evidence of clinical activity right off the bat. And they did something very interesting in this trial. They used FDHT PET. So this is a radio-labeled dihydrotestosterone PET scan, which was used as a pharmacodynamic marker of response here. And actually, this is an example of a patient that had a pelvic bone lesion at baseline, which again, this is not conventional PET, this is DHT PET, disappeared after 4 weeks of therapy. And when they looked at the different dose levels, they found that once you get above a certain dose level of ARN-509, this DHT becomes inhibited. And so when they were doing their phase 1 trial, instead of looking for a maximum tolerated dose, which they didn't actually achieve, even at the highest dose level, they picked the recommended phase 2 dose, not based on toxicity, but based on what they called maximum optimal biological dose, which is based on this FDHT PET. And the best optimal biologic dose was chosen as 240 milligrams, which went into the phase 2 and then subsequently into the phase 3. Now, from the phase 1 study, the toxicities, if you look at the grade 3 and grade 4, these columns are almost blank. You see a lot of zeros, so that's always a good sign. And if you look at even the grade 1 and grade 2, they're not that common. Fatigue was the main one, as well as diarrhea, nausea, and constipation. So again, for those of us that have used this drug, it tends to be manageable. One thing that didn't really come up in the phase 1, but we've seen a lot more in the subsequent studies, is a rash. And it tends to be a photosensitive rash, which occurs in the sun-exposed areas of the skin. It tends to resolve with very low dose topical steroids or sometimes on its own. But there have been a few patients in the phase 2 study that came off because of the rash. Didn't really seem to occur in the phase 1. And then this trial rapidly expanded into a phase 2. And the phase 2 had basically 3 populations of patients. The first was a non-metastatic CRPC population. The second was a sort of first-line CRPC. These patients were abiraterone naive, enzalutamide naive, and chemotherapy naive. And then they had a third population, which was also chemotherapy naive, but these patients had all received abiraterone, not enzalutamide, and they had to have a response to abiraterone. So these were patients that did not have primary resistance. They had responded for at least 6 months. And of course, again, the data looked pretty good, at least equivalent to enzalutamide, maybe a little bit better. So in the non-metastatic patients, almost every single guy had a PSA reduction, and that was true whether or not they were sort of M0 or M1 CRPC. as long as they hadn't received abiraterone or chemotherapy, the chance of responding was quite favorable. However, and this is the key here, is does this drug have any advantage in the post-abiraterone setting? And it doesn't look that impressive to me. If you look at the actual PSA 50 responses, it's probably around 20 to 24%. So again, the resistance mechanisms are building up here. After prior abiraterone, even a drug like ARN-509 may not have a huge advantage over enzalutamide, but there was some level of activity. And of course, as you would predict, this is the PSA progression-free survival, and this is the clinical or radiographic progression-free survival. The red curve basically shows you the patients that had previously received abiraterone. And of course, you have to remember, these were patients that responded to abiraterone for more than 6 months. So these were not truly the primary resistant patients. And yet, as you can see here, a PSA progression median of 3 months, again, pretty poor. However, in the naive patients, whether they were M0 or M1, the responses were fairly long-lasting. Now, I do want to talk quickly about this F877L. Actually, the nomenclature for AR gene mutations has recently changed, and this is the correct nomenclature. That was the old name. And this was, of course, the Balbus and Sawyer's paper that made a big splash. It was published in a journal that I had never heard of, eLife, but actually I think it was the inaugural issue, and Charles is on the editorial board of this journal. But they looked at this, these cells which were passaged under the influence of enzalutamide, and what they saw was the emergence of these cells that had this single amino acid substitution where phenylalanine was converted to leucine. And that was at position F877L. And interestingly enough, that's in the ligand binding domain, and that single amino acid substitution causes a 3D conformational change in the LBD, and the conformational change now makes enzalutamide a pure agonist, not just a partial agonist, a pure agonist of the androgen receptor. And this was published. And then, of course, the question is, does this also affect ARN-509? And it does. These drugs both bind to the same exact pocket in the ligand binding domain. And this was a subsequent study that was published using the phase 1 experience. And from the phase 1 study, 3 of 29 patients in that study that I reported from Dana Radkoff had this mutation. Now, the interesting thing is this mutation was never present at baseline. So in those 3 patients, it was always acquired over time. So it was acquired during or after the use of ARN-509. And this shows an example of a patient. So this is a man that had a PSA of about 100. He had a deep response, lasted at least a year. And as you can see, his PSA begins drifting up. And then using a circulating tumor DNA assay to look for this particular mutation, you can see here the F877L mutation first became apparent, but the patient was still clinically benefiting. He was kept on the drug. But then with time, that patient basically developed a resistance. Now, in the phase 2 study that I talked about a second ago with the 3 cohorts, they did another analysis of this same mutation, F877L. And here, again, these patients were generally less heavily pretreated. They had not received abiraterone, enzalutamide, or chemo. And here the incidence was a bit lower. But probably the true incidence of this mutation is going to be somewhere between 4% and 10%. And again, this is not really a primary mechanism of resistance. It's an acquired mechanism of resistance because this mutation is it evolves under the selective pressure of both of the drugs, ARN-509 and enzalutamide. So the second one is ODM-201, and the point of this this little picture here is, if you see the chemical structures of enzalutamide and ARN-509, they're virtually identical, with the exception of this part here. And this just makes the point that actually ODM-201 has a different chemical structure and therefore might be expected to behave differently. If you look at the CNS penetration, can't read that. So this has a 29, enzalutamide has a 29% CNS penetration. We used to think ARN didn't penetrate. We now know that it does, but it's less, 19%. And if you look at ODM-201, only 3% of it gets into the brain. So of the 3 anti-androgens, this one is the one that crosses the blood-brain barrier the least. And this shows that ODM-201 has a much higher affinity for the ligand binding domain of AR. So if you look at this AR wild type affinity, and you see that ODM has a higher affinity than ARN, and ARN has a higher affinity than enzalutamide. If you look across the column, if you look at its ability to antagonize the ligand binding domain of the wild type AR, it antagonizes it more potently than both of the other agents. If you look at the T878A mutation, which was discussed by Mary Ellen, actually the best inhibitor of that one is enzalutamide, the worst is ARN, and the intermediate is ODM. But interestingly, this F877L or F876L, depending on your preference, which is the agonistic mutation for enzalutamide and ARN-509, is actually inhibited by ODM. So when this drug was being developed, sort of one of the selling points was that this drug could have activity against that particular mutation as well. And then when you look at its ability to inhibit VCAP, it's actually superior to both ARN and enzalutamide. It also doesn't have any interactions in terms of induction or inhibition of any of the cytochrome P450 enzymes. So Karim Fizazi published this phase 1/2 study. So the inclusion criteria here were a bit different than the ARN-509. So all patients had to have received at least one first-generation anti-androgen. They were also allowed up to 2 prior chemotherapies, which was a difference between the ARN study. And there was also a subset that patients had received abiraterone. And patients that had a history of seizure or increased risk of seizure were not excluded. And this was different from all the other trials of ARN, as well as enzalutamide. So this is the phase 1 component. They enrolled 24 patients. This shows the waterfall plot for PSA response in the pre-chemotherapy patients, and these are the post-chemotherapy patients. The drug seemed to be well tolerated with some sort of non-specific AEs, decreased appetite, nausea, diarrhea. And of course, they saw anti-cancer activity here in most doses, including the first dose level. And 81% of all patients at all dose levels had a 50% PSA response. The pharmacokinetics, as you can see here, looks like up to about 1,400. It goes up linearly and then it peaks. And then this was the phase 2 expansion. So what I want to highlight here is they had sort of 3 populations. They had a chemotherapy and abiraterone naive, a post-chemotherapy but abiraterone naive, and then a post-abiraterone. And if you look at the waterfall plots, it's actually quite interesting. The main thing that blunts response to this agent is exactly what you would expect. It's not the docetaxel, it's the prior abiraterone. So yes, docetaxel does cause some cross-resistance, but the main cross-resistance is seen in the post-abiraterone. And those PSA responses, they are very, very infrequent. Like, I didn't do the calculation, but it's less than 10%, as you can see. So again, a common theme is really occurring here, which is that drugs that all inhibit the same thing, which is the ligand binding domain of AR, are going to have cross-resistance. And they're going to have more cross-resistance with each other and still some cross-resistance with docetaxel. And once again, of course, the patients that were chemotherapy naive and abiraterone naive, no surprise, had very beautiful clinical outcomes with this agent. But in this case with PSA progression and also with radiographic progression, and the post-chemo and the post-ABI in terms of PSA progression look the same. But if you look at the radiographic progression, the worst of the worst were the post-abiraterone. Here, the toxicities, again, were extremely mild. In fact, in this trial, there were no grade 4 at all. Even the grade 3 toxicities are in the single digits, 3%, 2%. And again, the safety is pretty good here. Fatigue, some arthralgia, some constipation, some nausea. Those are the main ones that sort of stood out. So again, these drugs are extremely safe on the whole. And this is my last slide. So the phase 3 development of these agents is exactly the same. It's almost identical. In fact, the trials are almost copied and pasted from each other. So these are all going to be tested in the M0 CRPC patients, so the non-metastatic CRPC. They both use a 2-to-1 randomization. These are probably going to be the last placebo-controlled trials in prostate cancer that we're ever going to see. And in order to make this attractive for patients, they had to skew it in favor of receiving the active drug. And of course, metastasis-free survival, which is an unproven and sort of uncharted territory, is the primary endpoint for both of these studies. And I should say enzalutamide, as Andy mentioned, also has a similar trial design called PROSPER. So there's now 3 trials, each enrolling anywhere between 1,000 to 2,000 patients trying to answer this question, and they're sort of all racing against each other. The one that opened first is the so-called Spartan study, but I can tell you that all of these trials are having great difficulty with accrual for obvious reasons, the main reason being the placebo control. And these are my acknowledgments. I'd like to thank Dana and Kareem, who were probably the first and second choice for this lecture, but they probably couldn't come, so I got many slides from them.
I've made a whole career out of being the second choice for something working with Eric Small, so don't fret.
No, the first choice, I can tell you.
Emmanuel, I'm interested in that 25% that does have a good response to sequential second generation or third generation drugs. Have you seen any biomarker work, particularly on the tissue? Like, why are those guys responding?
Well, with these particular agents, I haven't. But, you have to think about the mechanism of resistance. So if the AR splice variants are present, if that's driving it, then none of the anti-androgens that bind to the ligand binding domain, should work. If the mechanism of resistance is something else, let's say if it's further AR amplification or further ligand increases like CYP17, then in those patients, in the absence of splice variants, potentially, those might still be sensitive to the next agent. But I think a lot more work needs to be done in the setting of these two drugs. I really don't know. I don't happen to believe that the F877L is going to be hugely important because, again, it's a sort of acquired resistance, and we're sort of learning about it after the fact. But in the meantime, the patient has benefited from the drug. Now, if you're going to go directly from one ligand binding drug to another, let's say if ARN-509 becomes approved, then it's going to be approved in the M0. So let's say you use ARN-509 and then you're contemplating enzalutamide. I don't know why you would ever do that, but let's say you were. Then you could check for that F877L. If it's present, obviously you don't want to agonize the AR, you wouldn't give it. But I think most of us wouldn't do that sequence anyway.
A little bit, again, on the F877L mutation, because you said it's kind of an acquired one, but acquiring a mutation seems to me a very inefficient way for a cell to potentially survive a stress. Because one, they got to get lucky, they got to hit that one and have the one flip. So my question to you: do you think it's just below the level? And also, again, if you have the one mutation, for that to be enough that is clinically relevant, that's at least 30 doubling times to be a centimeter tumor. So my question to you is: it at a lower level, and are we going to get a technology that we could maybe then detect it to know, okay, well, this one, it doesn't happen that frequently, but this one's going to have it, so we're going to have to approach that subset or that clone in the future? Because I just, I agree with you, it shows itself, but my gut is it must have to be there earlier.
Right. So the word acquired is probably a bit of a misnomer in the clinical arena. In that mutagenesis screen by Charles Sawyers, I think in that case it probably was acquired. The mutation developed. But in humans, I think there's probably a very small subpopulation of cells that have that mutation present in the tumor. Maybe it's 0.1% or 0.01%. In the studies that were being done with ARN-509, they were using circulating cell-free DNA, and they were doing digital droplet PCR. And their ability to detect that mutation, I think, went down to 0.1%. So that's pretty darn sensitive. Now, of course, if it was 0.01%, it could still be missed. And it might not really be a driver. That's the other question that we don't really understand. We know that those drugs will knock out the wild-type AR-containing cells. So maybe by knocking those out, the other cells, of course, survive, and then they repopulate the tumor.
But even if it's 0.01% and it's pure agonist, you're activating it, right? So it doesn't matter what percentage it is. You're causing the selection if that's the case. I didn't see this in the data. Is the F877L, that data, when that emerged, what was the duration of exposure to the 509 or what was the duration of exposure before that?
It became apparent after about between 6 to 12 months, and it's interesting because in that AACR presentation that Dana gave, she didn't show the longitudinal data in those patients in terms of how long they responded. And if you look at those 3 out of the 83 patients that were positive at the time of progression, the one guy had a very long response. He responded for like 18 months. So for him, it was not a prognostic factor. In the other guy, he almost had a primary resistance where he had like radiographic progression in 4 months. And then the other guy had an in-between response. So it was only 3 out of 83 patients, so she didn't want to draw any conclusions. And she didn't even present it, but I asked her. And so there was one guy that had a primary resistance, one guy had a very long response, and one guy that had an intermediate. So the jury's out.
Not helpful.
Not helpful.
Yeah. Did they have a withdrawal response?
They did not look at that, but that's a key question. I would be interested to find out.
Well,
You would expect that they would.
that's exactly what I was going to ask. Your presentation suggests that some patients may benefit from enzalutamide withdrawal, and whether is anybody studying that or looking at that or reporting that?
Well, you know, when that abstract was being circulated to the authors, we all asked the same thing, and Aragon somehow did not want to release that data at the time. It was before it was J&J. And Dana didn't have that data either. So
I think there have been anecdotes of abiraterone withdrawal, ARN withdrawal, and enzalutamide withdrawal. Now the question is, has anybody linked them to the molecular changes? But great, good discussion.